guys, and welcome to episode 166 of the OCDstories.com podcast. Now, in this episode, I interviewed Dr. Maggie Perry. Maggie is a licensed psychologist who created the online anxiety and OCD group therapy platform huddle.care. Now, for those of you who aren't aware of huddle.care, we fully go into this. What is it? Why she started it? How it works? And then Maggie explains more into the workings of OCD, anxiety and panic, which I found really interesting. Then I asked Maggie all about her experience of doing teletherapy. So that is basically doing therapy over a video conferencing service. So where you're not actually with them in the room, but you see them over the laptop or whatever device you're using. Then I asked her about group therapy because it's not something we've really talked about on this show before. So Maggie answers it both from a online group therapy and also in the real world group therapy. So that was interesting. And then I asked her a question is, what have you noticed from your clients who recover much quicker than those that maybe take slightly more time? And also just words of hope for you guys. I really enjoyed chatting with Maggie. I think she really knows her stuff, so I'm happy to share her with you all, and I hope you enjoy the episode. And if you do find it useful and you get a moment, please do leave me a review on iTunes or wherever you listen to this, because it helps me reach more people, and I appreciate it. So without further ado, here is Maggie. On the podcast today, I have Dr. Maggie Perry. Maggie is a licensed psychologist who created the online group therapy platform huddle.care. Huddle.care groups are centered around acceptance-based commitment behavioral therapy for anxiety and OCD. Welcome to the show, Maggie.
Thank you, Stu. So happy to be here with you.
No, thank you for coming on. So as you know, I always get people, it's usually their OCD story. I don't know if you have OCD or not, but if not, you are a psychologist. So I'd love to hear your therapy story, kind of why you got into working in this field.
Yeah, wonderful. So of course I suffer, but I think a better version of my story is just to know that basically I had some very inspiring teachers in high school and college and identified really early that I wanted to be a psychologist. I got my doctorate in Baltimore and then did my doctoral internship and postdoctoral fellowship specifically in anxiety disorders. And then I went out to California and had a private practice. And now I am based in Chicago and I have this telehealth service. So the other thing that I think is a big part of my story that I want to mention when I talk about being inspired as a young person is really that the format of huddle.care was inspired by my basketball team. So I was a total practice player on this basketball team. I had a good jump shot, but I couldn't go left. So anyway, my coach was awesome and he did two things really, really well. So every Friday we had to commit to a good decisions form. And in this form, we basically committed to respecting our bodies and doing our homework, coming to practice. And for adolescents, that's a really vulnerable time. And what was amazing is that we all made those commitments and then actually acted on them. So just seeing the way a team could come together, commit to the same thing, and then kind of use each other's motivation to engage in positive behavior is now very inspiring to me. And then the other thing he did was this thing called the Coaches Award. So before every game, he singled out one girl and said, this is what she's doing awesome, both on the court and off. And it was amazing in terms of our group development because we were never jealous. We were never competitive. When he was saying what she was doing right, we were all kind of thinking oh, wow, cool, I could do that too. So I really learned about positive reinforcement at a very young age, even before I studied psychology. And I think between being very process oriented as a practice player, process over outcome, committing to positive change and sticking to it, and then also understanding the value of positive reinforcement, I really feel inspired still by that team in all the work that I do now.
Oh, wow. Yeah, no, that's a good story. And are you still in touch with some of your teammates from back then?
Yeah, absolutely.
Okay, good. That shows you the kind of bonding and connection that came out of it. Cool. And your training was in Baltimore, you said? And and then you straight away you went to San Francisco to set up your private practice?
Yeah, so right after my postdoctoral fellowship at the Anxiety and Stress Disorder Institute in Baltimore, I went out to San Francisco.
Oh, cool. And how long were you in San Fran for?
Just over a year.
Oh, wow. Cool. Didn't like it that much. Joking.
We had some other opportunities in Chicago.
Okay, good. Cool. Thank you for sharing that. And people are probably wondering at this point, kind of, what is huddle.care? So let's start there.
Great. Yes. So huddle.care is primarily a group treat online anxiety and OCD group treatment community. But it doesn't just include group therapy. It also includes what I call community time, which is like basically an education time where everyone meets together and talks about both their progress and different concepts that are related to the curriculum in the treatment program. So the components of the program are community time, which is up to between 20 and 30 people come to community time. It's part lecture, part application, and then also people reporting, like, this is one thing that I've done well this week. And then the group therapy are hour-long online sessions where 3 to 6 people show up and get to talk kind of in a semi-structured way about either a process that they're stuck on, like perfectionism, or like a moment of suffering they had that week. For instance, I had a panic attack on the train and I got stuck there. Let me talk through how I get through that. So we set a different agenda every time, but there's pretty similar themes each time also in the group therapy. And then some amount of the members also get individual treatment. So that is also an option.
Okay. Yeah, no, thank you for explaining it. And I mean, you did kind of allude to it with the basketball story. But at what point, sorry, how should I say this? Kind of, yeah, why start it? Was it you were treating people one-to-one in San Fran or in Baltimore, but you felt something was missing or something could have been better, or, yeah, what kind of kicked in?
Well, so I was aware of the power of telehealth because I moved several times pretty quickly, like over the span of 3 years. And I'll get more into what I think of the power of telehealth. I hope I have the opportunity to get more into that.
Yeah, I got a question for you.
Okay, great. But in terms of what inspired me to format the group the way that I did, I actually would prefer to step back and like set up our framework for the theoretical framework first, and then you'll probably be able to see like why I've made some of the decisions I've made. Cool. Is that an okay place to go?
Absolutely, yeah.
Okay, awesome. So in terms of the huddle care framework, let's just get on the same page about what we believe about anxiety and OCD. So modern science sees an anxiety state as a normal, natural, healthy, and adaptive reaction to a threat or a perceived threat. So in the presence of a threat, we've got the fight response, plus we have sticky catastrophic thinking. So our heart rate goes up, our blood pressure increases, our blood shoots out from our stomach out to our arms and legs. As our muscles tighten, we get ready to either fight or flee. And so in the Western world, because most of us breathe from our chest rather than from our bellies, as our muscles tighten up, it briefly can feel like we can't breathe. Lots of people take a deeper breath like this and then breathe out like that, which exhaling too much is no problem at all, but it can shift your CO2, especially if you're doing it chronically or you're doing it suddenly. And as your CO2 shifts, you can feel dizzy, you can feel tingly. At extreme, if you're really hyperventilating a lot, you can even feel depersonalized. So a lot of the sensations that make up what is an anxiety state or later an anxiety disorder are basically that fight or flight process plus sticky catastrophic thinking. So it's important to recognize at this point that an anxiety disorder is not just lots and lots of anxiety. It's an anxiety state plus avoidance or resistance to that state. Because way back when, like if you think about it from evolutionary terms, if I'm running from a lion, having all those sensations and then having quick, sticky thoughts like, should I keep running or should I jump in the tree? It's totally adaptive. And when the lion is gone, the sensations are going to peak and pass. I'm going to go back to resting. It's going to be great. So the problem is now in modern times, because what we fear is not this tiger in the bush, but rather, will I be healthy? Will I be safe? Will I be happy? Will I be loved? There's so much uncertainty. And a lot of those things, you can't even really get them answered at any given point. And basically, if our minds can imagine something, we can also fear that thing. So in modern times, we really have to have a strategy for how we're going to relate to uncertainty and anxiety, just because we have good bodies, but now what our minds can do does not fit what our bodies were meant to do in the first place. So with that in mind, you can think about the different diagnoses just based on what we do in response to uncertainty and anxiety that keeps those states going. So panic disorder is basically fear of sensations and avoidance and response. So for instance, I can be on the train and my heart starts to race and I say, oh no, why is my heart racing? What does this mean? What if it doesn't go away? What if it becomes a heart attack? Even if my psychologist told me that I'm not going to have a heart attack, what if it just never goes away? And I'd better get off the train. So that's kind of the panic process. Comparatively, social anxiety is primarily fear of judgment, rejection, and the feeling of embarrassment. So that'll be something more like I'm at the party. I notice that it's hard to come up with my words, or I'm noticing that I'm having sensations and I'm having trouble like staying on task, but rather I'm thinking, what if I blush? What if I say something stupid? What if I criticize myself after this and I, can't recover from it? And so I might avoid either my own emotional experience or the situation itself in terms of social anxiety. And then the last thing I want to frame up is kind of the difference between generalized anxiety and OCD, where in my training, we saw it as a spectrum between egosyntonic and ego-dystonic thinking, and those are just fancy words basically for how reasonable it seems to you. So with worry, I might have the thought, what if I lose my job? And then I might overwork to try to make that fear go away. I might get reassurance from my coworker. I might check and recheck emails. But basically, the intrusion was, what if I lose my job? And then the behaviors are what I do in response to the intrusion to try to make it go away. So similarly, OCD has this quality where it's ego dystonic. So it doesn't seem reasonable for me to worry about it, where I could have the thought like, what if the door isn't locked, even though I saw my hand lock the door? And so there's this quality of like, why do I feel uncertain about this? But I really hate the feeling of uncertainty, so I better just check. And the more that I check, then the worse it gets, as you obviously know. So anyway, this is a framework that I start with everyone. And from there, then we talk about, okay, if it's avoidance that's creating, maintaining, and intensifying our suffering, then it's a therapeutic, willing acceptance that's going to get us through our anxiety and our OCD. So all of treatment should be about adopting an attitude of willing acceptance. And so huddle.care is in alignment with ACT philosophically, in the sense that we're going for psychological flexibility as the key to living a rich, full, and meaningful life. And then what I tie in is, as we're trying to show up to the present moment, get distance from unhelpful thoughts and feelings, and commit to what we care about, we have these different stuck points. And Joan Davison and Shelley Frank have a great transdiagnostic model about the mechanisms that keep us stuck. I know that Joan has been on your podcast. Yeah. So I work with her, and that model is what I use in addition to ACT principles to help people see when they're stuck, why are they stuck. So then finally, within the groups, even though people can come and report on basically whatever it is that has happened to them that week, I'm typically thinking about it from two key processes, and that's in panic, social anxiety, and sometimes worry. We've got anticipatory anxiety, situational anxiety, and then post-event processing. Whereas in OCD and sometimes worry, we typically have shame and then uncertainty and doubt, and then guilt for probably that I did my checking. And so different interventions that I use in community time versus group therapy kind of map onto the understanding that people can be stuck at any one of those points.
Okay. No, thank you for explaining that and going into it. And also between the different sort of diagnoses. And I know panic is probably something many of my listeners have experienced. It's not something I've really covered as of yet on the show. So it's good to go into that a bit as well.
Just if I can comment on that again. Yeah, that's where I think people can be afraid if their provider says, well, you have panic and OCD and social anxiety or something. So if we think about it as these processes, basically those are just labels saying you have fear of sensation, you have fear of thought, you have fear of embarrassment. And we'll see where the diagnostic system goes in the future. But at this point, it's more helpful to think about my anxiety disorder label is signaling what I'm avoiding and what I should go towards, not like meaning that I'm more and more impaired, I guess. There's no reason to be afraid of the diagnoses. The diagnoses should actually signal this is what we want to go towards.
Absolutely, and that's where the transdiagnostic model comes in, and you see why they brought out the DSM, the book of diagnoses, effectively, because it's useful for knowing which medications, and it's useful for knowing which therapies work best for which things. But as I always kind of say, after that, like, it's all just a load of electrical impulses in the brain. There's no neat boxes like this part of my brain is OCD, this part is. It's all kind of firing together and not together. Like it's humans that kind of put it into categories, not the brain. But yeah, so I think that's useful as well, starting to understand how your brain works beyond kind of boxes and kind of just looking at the processes of the brain. So one question I know I get is about, like, how does ERP fit into this or not fit into this?
Wonderful. Yes. So I'm trained in ERP. Many of the members that I work with have had OCD diagnoses for a really long time. So many of them have been through good ERP treatment. And where I think, so if I can work with people that have not been in individual treatment before or some other type of treatment before, but it's often, especially, your listener that has heard experts talk about this, people that have read a lot of books will often be able to pick up the process really well. And even there's some really good books these days or apps these days that actually can really help you figure out how to do ERP yourself. And where I think huddle.care can really picks up where the books leave off or where other forms of treatment might leave off is the shame and the guilt part of it. So again, back to the OCD process being basically I have an intrusion, I feel both uncertainty and often shame, and then I get in my doubt and uncertainty spiral that involves all my compulsions or avoidances. And then I feel guilt because I know that that's actually making it worse for me, but I feel like I can't get out of it. And then if I'm stuck in my guilt, that's hard to get out of. I have a new intrusion. Now I feel shame again. Now I'm resensitized. Now I'm back in my loop. I feel guilt again. I get shame again. So shame, what we know about shame is that it makes us it feels as though we are bad, like having the experience in the first place is as though there's something broken or wrong about me. And it makes us want to hide from others. So when you share your shame, then you're building shame resilience because you're connecting with others who hopefully will give you a compassionate response. And then you feel more connected again. You're back in connection. Your sensitization comes down. Now you can actually access your skills. So for a person that has really put in a lot of effort for ERP, but either has some content areas where the ERP is just not working the same way, or they have new content areas that just like spring out of nowhere and catch them off guard, and they get stuck again. Often, like thinking about how shame might be involved can be really helpful to, again, like helping someone access the skills that they already have. And I think you need to be in community in order to overcome shame. It's like not something you can read about or even like journal about and overcome. You need to be in community.
Yeah, that's interesting, because something I've heard more of recently and something I can look at in my own experience in life is doing this podcast, and I mean, I don't share my story as much now as I did a few years ago on it, but I still occasionally drop little bits here and there, kind of like I'm doing now, and sharing that story and connecting with others has done wonders for kind of decreasing my shame. So many other advocates I've spoken to have said the same thing, that doing advocacy, although very hard at the beginning, has done so much for them in their recovery.
Yes, that is completely consistent with what I believe too. And I don't think it's just stigma or self-stigma about like the label itself and the longer narrative. It's also like very subtle shame, like immediately when the intrusion occurs. Particularly if you're coping with harm OCD, but even like contamination OCD, which people don't typically feel shame that they're afraid of contamination. But if they suffer and struggle with contamination OCD for a long time, 3 o'clock in the afternoon when they get that intrusion and they have the urge to do those compulsions, that typically is tinged with shame because they just don't want to be in that process anymore.
Yeah, very good point. I can relate to that. Okay, so before we kind of get into teletherapy and why groups work, a couple more questions around huddle.care. So we've talked before off air about positive change logs. It'd just be good to go into what that is and why they're useful.
Yes, wonderful. So I guess in terms of the structure that the program does have is in community time, everybody comes to community time and says one moment that they're proud of. And then at the end of community time, everybody commits to something. And same with group. You don't say what you're proud of. You say, like, what do you want to talk about today? But you also commit to something at the end. And then so that ties into the positive change log in that just having the community show up and say, this is what's going well for me is a huge exposure for lots of people with OCD because, you fall into the all or nothing thinking that like, if most of the week I was compulsing, then it was a bad week rather than like, well, there might've been one moment where like the moment that you stopped compulsing is worth talking about, or the delay that you had before you started compulsing, that's worth talking about. So what I'm really going for there is actually increasing behavioral repertoire. So if we go back to the goal is increasing psychological flexibility as the key to living a rich, full, and meaningful life. And again, what we mean by that is we're not trying to be happy all the time, but we're trying to make it more likely to have more types of states. So more types of thoughts, more types of sensations. If we've got a bunch of variability there, there's going to be times where we feel joy, we feel contentment, we feel connected. And then overall, we're also committing to things we care about, and that makes us feel like we're living a good life. And so with that in mind, I don't want to focus on, I do help people with what they're stuck on. That's what group therapy is for. And we really get in the weeds on that. But I also want to know when you had a good moment, what helped you be willing to get there? And then how can I reinforce what went well there? So I see the positive change log as setting up realistic expectations for what this process of overcoming anxiety and OCD is actually like, which is that it often is a very gradual change over time. It's not like if I set up my ERP perfectly and then I stick to it perfectly, I'm never going to suffer again, but rather I've got to I have to use trial and error gradually over time with curiosity and compassion, and eventually things will click like, oh, I do have other options when I feel stuck like this. And even if I don't, actually it's better if I don't use the same technique every time, because what I'm going for is having more flexibility. Yes. So basically positive change logs give me the opportunity to reinforce things that are going well. And overall that increases people's behavioral repertoires.
Yeah, no, I can see why that works. And so with huddle.care, I met your partner through 2 and a bit years ago. It's at the ICF conference in San Fran, 2017. Yeah. I can't remember, July, wherever that was in time. It was nice to meet him, and he obviously talked to me about huddle.care all the way back then, and I think that's when you guys were starting it. Yeah.
Oh,
So
yeah. I can fill in the blanks on that transition. So
yeah.
basically, yeah, like how I came up with what Huddle is now. So I did a bunch of group therapy. Group therapy is, part of typical training. So I did different groups early in my training years. I did social anxiety and harm OCD groups at the Anxiety Institute, and in particular, I did a harm OCD group that really it was actually for men with fear of hurting their babies or other loved ones,
Mm.
and just the way that they could connect really help them cope with their shame in a way that was incredibly powerful for me. And I was just like, this is it. This is this is how you help people. So when I went off to San Francisco, I also started some small groups. That was kind of like normal private practice. And then as I transitioned to Chicago and asked my practice if they wanted to continue to work with me online, I put some of the groups online. And then as I was getting new referrals, I realized that showing up to group is not quite the same thing as going to like a fitness class or a yoga class, in the sense that the person next to you doesn't matter. Actually, the person next to you matters a ton. And if you don't feel connected to the other 4 or 5 people Monday nights at 7, it's going to be hard to stay motivated to stay in group therapy. So I think a lot of people know that group therapy is really effective and can be effective above and beyond what individual is, and I can talk about that in a little bit. But yeah, I think just getting groups going and then getting mixes of people that fit really well can be tough. So what I thought of is, if I add this community time, basically if I make a bunch of different times for groups, and you don't have to commit Monday night at 7, but rather you commit by the month, and then there's groups at a bunch of different times, then people can have flexibility. But also, if you join a group and you don't really connect with the other people, you can always try a different group the following week. So part of community time was also that I wanted to a big part of overcoming an anxiety disorder or OCD is just having education about stuff like the physiological response. And as a psychologist, I was spending like a ton of time as an individual provider saying the same thing over and over. So I really just wanted to clump all that information together and give people that information all at one time. And then the other thing is, I wanted people to have the chance to meet other people that are potentially in the small groups, so that, for instance, when somebody is saying, I'm really proud of this moment where I related more effectively to my OCD, someone could be thinking, oh, I want to go to the same group that person is in because we have that in common. So basically, I wanted to overcome scheduling issues around committing to the same group every week, and I wanted to make it more likely that a new person could find somebody that they relate to.
Yeah. Oh, that's great. That makes a lot of sense. And
yeah. And so in this current model, it's been like 2 years since I've been running it this way, and people seem to like it.
Cool. Well, that was going to be my next question is, what's the response been from people using it?
Yeah. So I don't actually target compassion directly. Like, I don't target it in a formal way, but the results that people are saying is, in addition to like education, understanding their OCD and anxiety better, the increase in compassion is the thing that people talk about the most, which makes me feel so happy. But I think what's happening there in terms of mechanisms is getting to know people week after week, and then hearing what they're doing well, what they're struggling with. It's just so easy to feel compassion towards someone else. And then because people could see the processes that were maintaining other people's suffering, and then say like, oh, I'm actually experiencing this process. Like, I'm not doing this to myself. I don't want this to be happening. I'm just kind of tricked by the behavioral process that my body got into. It's easier to have compassion when you see other people describing the same thing. So that I feel great about that result.
Yeah, absolutely. Yeah, that's great. And we're going to get on to a bit on just teletherapy generally now, and then group therapy. Is there anything else specifically on huddle.care I haven't asked you that you wanted to discuss now?
I don't think so. I think we covered it. Thank you.
Yeah, no, that was great. Okay, so I had Dr. Stephen Phillipson on, 2 months ago, to talk about teletherapy, because it's not something I've talked about, and I know that actually for some people they can't get access to a OCD therapist near to them. So teletherapy is a viable option, and I wanted to just see if it was as good as kind of one-to-one. So kind of in your experience, because you've done both as well, what's been your experience between, say, being in a room with someone versus kind of doing video chat with them?
Yes. So I love video chat. It was partially my life circumstances that gave me the willingness to take the leap of faith and see if it was going to work. But now that I do it, what I think about it is, so our goal is if our goal is to see when you're stuck, why you stuck, so that we can increase your
Mm.
flexibility. And so while I'm observing and understanding your mind, it's not, I need to know your report on physiology. And actually, it doesn't, hopefully in the future, it won't just be a self report. Like different technology can help us actually understand in real time what's happening for someone physiologically. But so we need the physiology. We need the self report of what someone's mind is saying. But then I think we also need affect. So affect is really powerful because it's a powerful way to connect to people. But also, as a therapist, really important moments occur when affect and words are not matching up. So someone's
Just to
describing,
clarify, affect being emotion.
yeah,
Yeah.
yeah, and emotion in the way that someone is experiencing it in their face in particular.
Yeah.
So someone might be saying that they feel anxious, but they're actually angry, or they might be saying that they feel sad and they also actually feel ashamed. And I can see that on people's faces.
Mm.
So actually, in person, I'm all for in-person therapy also, but what I find now that I do this kind of therapy online all the time is it's much easier to focus on someone's affect and really see the nuances of what's happening for them, and you're not distracted by anything else in the room or actually your body. Like you're really looking at their affect while they're
Mm.
talking. And I find that I can really help people shift the mismatch there, and then also learn when you don't have language for your emotion. And oftentimes, whether that's because of like all kinds of different childhood situations that make it so that you don't have a lot of language around emotion, or actually the consequence of a anxiety disorder or OCD for a long period of time where everything feels like anxiety, so you don't get a lot of language or awareness of the feelings underneath the anxiety. So lots of people have trouble even bringing language to what they're feeling. So if I can see your face, I can give you language. And then that can also help your process. So I think comparatively to texting or apps, and even like telephone is not as effective because you miss out on the affect. But
Mm.
I really think video chat, telehealth in particular, is awesome because you have both the words and the affect.
Yeah. Yeah. Good point. Yeah. Thank you for going into that. Group therapy is something that fascinates me. I've been in a couple groups myself, and not long term, just short term. But there's something also I've seen in my own camps that I run. The things you've already talked about, I saw happen in that first camp that I ran last year. Definitely around the shame piece. So because we haven't really talked about it in this podcast, if it's okay, we'll talk about them generally. I guess bringing in either generally or bringing both groups online and groups kind of in the real world. So just talking about the idea of people with OCD being together in a therapeutic setting.
Yeah, absolutely.
Yeah.
Oh, go ahead.
So the
Sorry.
question was, just generic. It's just basically tell us about group therapy for OCD.
Great. Yeah. I mean, I do think a lot of the same processes are occurring in group therapy online as they are in person because you are seeing each other's affect and you're sharing your words and you get to see each other's faces. So that connection can be very similar. Um, but so I think about it from four different points. So there's education, increase in motivation, increase in curiosity and compassion. So outside of any I guess in the education piece, that's where we're talking skills development. So, like literal education about what is panic disorder, what is OCD, what maintains it, what different skills like mindfulness or ERP, scheduled worry time, these types of things that you'd also get in individual therapy where you're just learning what the process is and what your different options are for relating differently to it. So that can happen in a group setting. And it's not just a expert or like a therapist telling you, what your options are, but other people saying like, oh yeah, I'm struggling with insomnia also. This is what I do when I can't fall asleep at night. With kind of somebody guiding you and saying like, yes, this is helpful for that reason, or you might modify it in this way for your circumstance. That's where the therapist can kind of add in more guidance to what the group is discussing together. So there's certainly the education piece. I think in addition to skills and sharing information, the other thing is just hearing people describe in detail what they experience and realizing that you wouldn't have reported that. So, for instance, with mental compulsions, this is a subtle part of OCD that many people with OCD experience, but don't even think to report to their therapist unless the therapist specifically asks. So, if you show up to a group and someone is saying, I had this intrusion about hitting someone with my car, and now I'm going through a detailed memory check of every moment I've had for the last 2 days. Other people that also have that going on are like, oh yeah, that's also part of it's not just checking the door or asking my mom whether or not it happened. It's also that kind of process that I might not have reported on. So I feel like that's in the education piece where you actually learn more about your mind when you hear other people's minds. For motivation, I think back to kind of my basketball example of if everybody's committing to something and somebody just said, I was really anxious, but I held out in my anticipatory anxiety and I got up and I went to that job interview. Other people are like, yeah, like I want to apply for a job too. Like it can just increase motivation, which can be helpful. And then I think if the process is like rather than feeling guilty about the way that you're getting stuck, if you can get curious about other people's experience and like what worked for them, how do they keep it going, then again, you also get curiosity about your own experience, and curiosity is just a better state to learn in. So that can be really helpful. It can sometimes be hard to get curious in individual therapy if you are afraid you're doing something wrong, or you want to make like you really like your therapist and you want to be showing them that you're getting better. Then like sometimes it's hard to get in that state of curiosity that I think group can facilitate. And then finally, I kind of already touched on how group can facilitate compassion, but I just want to reinforce that I think feeling compassion towards someone else that you watch suffer can also help you feel compassion towards yourself.
Absolutely. And are there any people who benefit most from being in groups as opposed to, say, one-to-one? And is there anyone who does sort of worse being in groups versus one-to-one?
Yes, I think that at least the groups that I run are you've got to have enough psychological mindedness to observe what's happening and be able to describe that as a process. I mean, we also help with that, but when there's a lot of different co-occurring problems or potentially like a lot of life circumstances that are sensitizing the person and maintaining some of what's occurring, that person probably does benefit from talking it through one-on-one because they just may need more time to differentiate between what is actually anxiety and OCD and what is actually your life circumstances. So that person may need more individual support. I think trauma, when you're first starting to go towards trauma, that like very safe relationship with one-on-one person is an important time to like understand what happened, get yourself safe again, get some language around the narrative. I think then trauma survivors that can be in groups, that can be wonderfully healing, but sometimes like a trauma survivor really benefits from the safety of a one-on-one relationship. And then at least for my groups, somebody with an active substance abuse problem, active suicidality, or active psychotic symptoms are not necessarily indicated for my groups, mostly just because these people would need like a higher level of care, and the processes that maintain those problems are different than the ones that we focus on. But I actually think there's tons of groups out there that really do wonderful things for suicidality, for psychotic symptoms, and for active substance use. So it just in my experience, we just focus on different processes.
Yeah. Okay. No, thank you for explaining, I should say. And as you said earlier, a lot of the people that come to you have probably done one-to-one therapy as well, and got to a point with it, and for whatever reason, maybe want to try something new, or
Well, the other thing is, because anxiety disorders are chronic intermittent problems. So, you've got the biological vulnerability that runs in the family, and then it's manifests based on stressors. But I think Claire Weeks, who wrote Peace from Nervous Suffering, so she said you'd never want to live such a charmed life that you never get resensitized, which I love. But so that is just saying that, like, again, you're going to have this biological vulnerability. It's probably coming back, but hopefully it doesn't cause you distress or impairment like every day the rest of your life. So with that in mind, if you go through a really good program of treatment and your symptoms subside, you may not want to go. Treatment can be really expensive. So going back into one-on-one, like as soon as your symptoms show up, can be like a pretty difficult decision, because it's like, it's not impairing me yet, and it's kind of expensive. Should I go back yet? So honestly, part of the group model is it's much more affordable. And the idea, I've only been doing it for 2 years, but already I've had members that do this, where you can be part of it for a couple months, and then you're feeling better, jump out, come back, a couple months later, or a couple years later, hopefully. And it doesn't feel like a really big decision, like, oh, how am I going to find another provider? How much is it going to cost? I'm not going to wait until it gets worse. So it's kind of a preventative model also.
Yeah. Cool. No, that's an important distinction. Cool. Okay. Thank you for that. That was useful. A sort of general question I usually ask therapists or psychologists, because of the belief that success leaves clues. So what have you noticed from your clients who seem to make progress much quicker than some of the others?
Yes. So I don't believe that severity predicts prognosis. So just because you're really stuck and really experiencing a lot of intrusions and a lot of compulsions or a lot of anxious avoidance doesn't mean that you can't make quick progress. I think the people that do make progress get it. So you got to have curiosity. And Reed Wilson is awesome about having a strategic approach to your anxiety. So I do really believe that you've got to be able to, at least in adults, you've got to be able to see that you're trapped by the strategy that you're going about trying to overcome your anxiety, and the approach that you're taking is making it worse. And then you got to be open to having a new strategy. And if you can get curious about that and get open to having a new strategy, also people that can see humor and what's happening tend to also get better.
Oh, that's interesting. Okay, cool. No, thank you for that. Real generic question now is just words for hope for people with OCD.
Think about it as, rather than, I think the most hopeful thing I can think of right now is, rather than you only live once, you actually only have to die once, and you get to live every day. And given that these are processes that are observable, they're patterns that occur in other people, even if you feel trapped by it and you don't understand, someone else can observe it and help you with it. And other people have had the same thing happen to you before. It happened to them before. So even if you're stuck today, you get to try again tomorrow.
Yeah, love it. Good point. Okay, so let's say you could pick up the phone and call your 20-year-old self. What would you tell her?
You're going to have a really cool job. Yeah, I think when I was 20, I was just in the beginning of my study of psychology. So I think if I would have known actually what my career would become, I would have had less anxiety. And I would have felt really excited.
Yeah. Excellent. Okay, and you've got a billboard in Chicago. What do you want written on that billboard for everyone to see?
Avoidance creates, maintains, and intensifies anxiety.
Wow.
I wish, like, my dream is for the whole of population to understand that relationship between thoughts, feelings, and behaviors, and if everybody knew it's avoidance that's maintaining anxiety. So we just have to we search and destroy the avoidances, and then you'll get relief. I think that's part of my dream. So my dream is that that's just common knowledge, but beyond that is when your thoughts and feelings and the way that your mind is interpreting your thoughts and feelings starts to become painful or impairing, distressing to you, if like people just knew, oh, that's what, I'm in a mental health trap, and there's somewhere I can go. I can hop on a, super affordable video chat call. Other people are also experiencing this. I'm going to get some education and some motivation and some strategy for what I'm going to do differently, and I'm going to be able to get out of it. I just feel like that's my hope for mental health in the future.
Cool. No, I love it. And I love what you would write on the billboard. I think that's great. Seek and destroy avoidance. Okay, so is there anything else I haven't asked you that you wish you could have shared?
I don't think so, but I just want to say that Seek and Destroy Avoidances is coming from Sally Winston and Marty Seith. They have a couple good books that are really great and talk a lot about that.
Cool. Yeah, ping me the names and stuff after this, and I can put them in the show notes.
Great.
Cool. But thank you for your time. It was a pleasure to talk to you about huddle.care and going into groups and teletherapy a bit more.
Thanks so much, Stu.
So there you have it. Really hope you enjoyed my chat with Maggie. And if you wanted to find out more about her platform huddle.care and their treatment plans, then head over to huddle.care/OCD. That's huddle.care/OCD. And quick disclaimer, guys, this podcast is not therapy. It's not a replacement for therapy. Please seek treatment from a trained professional. And until we speak, take care.